Thank you, Jaime. Gracias, Jaime, for these very provocative thoughts. I saw and I heard many colleagues as you were describing the different challenges. I saw many faces being provoked by your thoughts, and especially the replica towards cost effectiveness analysis as one way to set priorities. And also very interesting how different countries are addressing the same challenge using different ways to do it. So our next panel is moderated by Han Fraeters. Han is the manager of the knowledge exchange team at the World Bank Institute. He will be guiding 4 of our practitioners, 3 from Latin America and 1 from the Center for Global Development, and they will be discussing the role of South-to-South knowledge exchange when addressing these challenges of right to health and universal health coverage. Over to you, Han.
Okay, let's just all come up front. I think that's the way to do it, right? So let's sit here, make ourselves comfortable. Please have a seat. I haven't not seen it. Please have a seat. Okay, so welcome to this panel. We are a little behind on the schedule, so we'll try to stick within our time frame. So in this panel, what we're going to look at is how knowledge exchange, the sharing of experiences between practitioners, between countries, is actually helping or providing inspiration to cut this Gordian knot. I must say I'm not a health expert. I'm certainly not a health expert, but I have rarely had a more fascinating introduction into a field or problem as we just heard from Dr. Caro. So thank you very much for that. And it's really providing a good basis for this discussion, because what struck me very much while listening to you, Professor Caro, is that you've been asking many more questions than providing answers. And I think this is probably why an initiative like this is relying so much on sharing experience and bringing people in touch with each other, because they have to share their problems and then listen to how others are dealing with these problems. So what we're trying to do today is really dig a little bit deeper into this knowledge exchange and how it has helped in different cases and in different situations provide answers to questions that are extremely difficult and where trade-offs have to be made. And we have a nice variety of people. We have a very varied panel. So we have concrete cases from countries, and we also have a little bit more of an overview of different experiences, and then some reflections from at the end. So our speakers are, so I suggest we start with Amanda Glassman. Amanda Glassman is the Director of Global Health Policy Center for Global Development here in the US. I'll also introduce the other panelists quickly. We have Mr. Fernando Castillo, who is the Judge of the Constitutional Chamber of the Supreme Court of Costa Rica. We have Alvaro Salas, who is a Director of Specialized Hospitals, the Social Security Institute in Costa Rica. And then we have Martin Schulze, welcome, who is the Judge of the Court of the State of the Rio Grande do Sul in Brazil. And then we'll end with comments from Keith Hansen, who is the Sector Director for Latin America for Health. So why don't we start with Amanda. Amanda, I understand that you've just...
I'll be quick, I promise.
Yeah. You've just published some an overview of experiences in different countries. Mm-hmm. So if you could talk a little bit about that, and also see where explain to us where you see the experiences for knowledge exchange.
Okay. Well, thank you very much for the invitation.
If you also want, you can also sit there. It's whatever you feel most comfortable with.
I just have a few slides, so I'll stand if that's all right. So we convened a working group last year that included some people from the countries that are sitting here, in particular Alarico Rodriguez from Uruguay, to look at what developing countries, low and middle income countries themselves are doing to set priorities in health and to make some of the difficult decisions that Dr. Caro discussed earlier. One of the issues that we have in health is that there's sort of an inertial and ad hoc resource allocation in most countries that results in very low value in terms of life years saved and high levels of inequity. So I'll just give you the Latin American example, but in Colombia, about 60% of children are fully vaccinated, and yet public money is used to subsidize the use of Avastin for the treatment of breast cancer. This is an extremely expensive medication that is not registered for this use by the U.S. Food and Drug Administration and is not authorized for payment under the National Health Service. Why does this happen? Well, there are competing interests. Assigning budget is political, and if you have an ad hoc process, it drives perverse choices. And one big problem that we have in low and middle income countries that's very different from the European countries and Canada is that there are many good value interventions, many things that will produce benefit, but very, very limited resources. Okay, so something that is cost effective will not be necessarily affordable. And making that distinction between cost effectiveness and affordability is really key. However, there are many forces converging that is making explicit priority setting necessary and possible in low and middle income countries. So I'm just going to talk a little bit about the findings of the working group in this space and then talk about the opportunities to interact more on this. So Dr. Caro talked a little bit about cost effectiveness and how difficult it was to define value and come to consensus on value. But, if you look at the universe of interventions that we can fund in health, the difference in the benefit, the life years saved, is so enormous between the least and the most cost effective that you really have to think twice before deciding, for example, through legal processes, to award the use of very high cost medications. So I'm just showing you in the little window here the difference in the cost effectiveness of different HIV/AIDS interventions. This is the amount of disability-adjusted life years that you can buy for $1,000. Okay, there's a 1,400 time difference between surgical treatment for Kaposi's sarcoma versus high-risk education for high-risk groups. And if you look at all 108 of the interventions that were examined by the Disease Control Priorities Project, the difference between the least and the most cost-effective is about 15,000 times. Okay, so that's not to say that effectiveness is the only important criteria to allocate resources, but there's fairness, there's equity, there's systematic disadvantage, there's financial protection. But it is to argue that if we do not look at this issue, we are making a very difficult moral choice, because we're failing at this very important moral imperative on how to achieve good value with limited resources at the expense of untold human suffering. So another feature of the landscape in our region is that the public spending is fairly low, but it's growing. So in 2010, Brazil was spending $431 per capita, okay? Venezuela was the highest spender in our region with $3,211 per capita. That is a very different scenario than choosing around $25,000 per capita, which is what it was a while back in the United States. And this higher health care spending has created a very large market for healthcare products and services, and that's part of the reason that we see a lot of legal cases, because we have a lot of direct marketing going on by industry. This just shows the sales growth in Avastin in 2010, and it contrasts the growth in volume of sales in the United States. The left is overall pharmaceutical sales growth, and on the right is Avastin. Okay? This is growth in the U.S., this is Europe, and this is Latin America and the Caribbean. Our markets in Latin America are where all the action is happening now, and that means increasing pressure on the public sector and health systems. Okay, so here's a picture of a meeting at the World Health Organization where we usually try to set priorities. Everyone's asleep. So I'll just run very quickly through this, but we got together this group of countries to talk about the different tools that were already available and being used by countries. So you'll probably all be familiar with the essential medicines list. It was established in 1977. Most countries have adapted this tool to set priorities. And yet, these priorities that are decided by a committee of clinical pharmacologists sitting in Geneva, okay, that consider cost effectiveness for the past 5 years or so, but they're not linked in any way to affordability or budgets in the countries themselves. So Herceptin for the treatment of breast cancer is on that list, and I was recently at a meeting with someone from Jamaica, and she said to me, in our legislation, we said anyone can have something on the essential medicines list, okay? But we can't afford to provide Herceptin. So, what do I do then? Second, and this is something that you will all be very familiar with, health benefits plans. Paquetes, planes, lists, or negative lists if you don't have an insurance system or payment provision separation. So this practice is growing, this idea of setting an explicit set of entitlements. It defines at least this and not that. It does not prohibit providers from doing more. And it can assure that there's connection between the budget that's allocated and the cost of this package per capita. And in Colombia, it's now structuring 70% of expenditure. It's 37% in Chile with the Auge package and 66% in Uruguay. But what have our problems been with this package? First, some of the measures were, the data was extrapolated uncritically from global data, even though costs are vastly different. Also, the epidemiology and demography is very different. There's a kind of lack of connection to available budgets in some countries. So, for example, in Mexico, they have started with a well-costed package called Cauces with the Seguro Popular. But in 5 years, it grew from something like 142 to 256 interventions. But the capitation payment attached to that benefits plan was only adjusted for inflation. Okay? So, that means that there's going to be other kinds of rationing happening if we're not going to ration ex ante. Another problem with these packages and plans is that many times they've been defined in a one-off way and there's no process in place to update. So if you think about the banks, I'm guilty, all of my colleagues are probably guilty here. You go to prepare a loan and you hire a consultant to design the package. 2 weeks, 1 month in the country, doing that rank order list of cost effectiveness and designing a package. That's not a great practice. The other issue, and I'm sure this is, I think, the main subject of what we talked about here, is unclear and indefensible criteria for including or excluding an intervention on these lists, which makes it vulnerable to legal challenge. If you don't have a fair process in place, there's no way to defend it in the courts. So this is just a list of all the countries that have packages right now in Latin America. I'm going to skip, sorry. Okay, and I think, the countries themselves are going on beyond simple lists by defining not just yes or no, but which conditions and for what subgroups technologies should or should not be provided. They're linking the list to clinical protocols and clinical practice guidelines, and it's a way to provide guarantees of some minimum level or basic universal level of rights. And then finally, health technology assessment, HTA. This is something that's going on in 9 countries of the world, including Brazil, Chile, Colombia, and Uruguay in our region. And these are agencies that are not just doing cost effectiveness analysis, they're also doing budget impact analysis, and they are starting to think about a deliberative process to consider the evidence and debate around the ethics and social value issues that Jaime Caro mentioned. And in the case of Thailand, for example, they are beginning to use these processes and agencies to connect their analyses with the decisions on what is included or excluded in a basic package. And they're quite inexpensive if you look at total public spending on health. Okay, and then just finally to position this, I'll come to my final slide in a bit. If you look at the number of projects that we have in this space today, supported by the international community, most of it is focused on academic studies. and much less is focused on collaboration and advice and know-how exchange between the countries that would help us to make better decisions on budgets. So the working group came up basically with a suggestion that a better process that would incorporate, yes, cost-effectiveness analysis, but also budget impact analysis and a deliberative process to deal with fairness, values, other kinds of issues that couldn't be quantified, to have that be codified, that would lead in turn to better funding decisions. So we're talking about, when we talk about health technology assessment in this report, we're using a broad definition of technology. It's products, but it's also interventions, okay? And we felt like there's no model that's going to work everywhere, but there are sort of core elements of what a fair and technically rigorous process might look like. And countries have some pieces in place and others not in place. So the first issue, and this would be the areas also around which I think there could be collaboration, has to do with registration of a medication or a product. So the minute such a product or technology enters a country, it's potentially available to the country health system. So some countries are starting to use their regulatory agencies as a way to look at cost effectiveness before allowing market access. This is really important. And there could be more done collaboratively and at a regional level. Second is the issue of scoping. Once a product's in, you have to decide what to evaluate first, because that decision in turn, are you going to start with the high-cost things you want to say no to, or are you going to start with the high-value things that are going to get you more health for the money? So that really depends on the country's priority-setting objective. If it's to improve equity, if it's to limit legal liabilities, if it's to address major disease burden, if it's to design or adjust a basic package, those are all places to start to decide what comes first. Then comes cost-effectiveness analysis that can build in elements of equity and financial protection, or other quantitative outcomes. Budget impact, so that way we know whether something's cost effective, whether we can actually afford it or not, and what the trade-offs are. And then with that whole set of evidence, convene a group and start a process that allows for deliberation. Finally, the idea is to connect this to decisions made by payer agencies, okay? So, lots of countries have academic institutions that are doing health technology assessment studies. So what? Unless it has some impact on the uses of public funding in a very systematic way, it will be irrelevant. And finally, there should be an appeals process. If new data is available and new evidence, it should come back into the discussion.
Running out of time.
Okay, I'm going to finish now. Okay. So I'll leave some copies of the report here, and that's also available online. But the idea that we had is there's certain economies of scale that could be accomplished through collaboration at the regional level or international or at the global level around this issue of registration, cost-effectiveness analysis, methods, data requirements to conduct these analyses, even institutional know-how. These are the kinds of things that, require that you have had to live these experiences, right? It's hard to communicate about these issues. So, is there a possibility to have a joint global effort to take care of these kinds of tasks as we go forward? So I'll leave it there.
Thank you, Amanda.